No, thanks, Seb, and once again, thanks for the invitation. Pelvic discontinuity, yes, that's of course always a challenge. I think everybody in the room knows what it is. The risk is 1% in all acetabular revisions, so it is more or less rare, but it is still existing. The risk factors are females, bone loss, and rheumatoid arthritis. What are the principles? I think there are 4 principles. First of all, you have to identify the problem. That's sometimes a surprise during the operation. Then you have to stabilize or to bypass the discontinuity, treat the bone loss, and obtain a stable implant. I think that's clear. And looking for all the strategies, we have seen some of them. Some of them were mentioned in the last session from the literature. It is more or less there are 4 strategies. So first of all, we can use an additional osteosynthesis to stabilize this. We can bridge this only, so not so popular anymore. We can get stability with fixation in the ilium. That's what the tumor surgeons do very often. And the best thing is, of course, to get stability through bone ingrow. At the end, what you have to do depends on the stability of the bone and the amount of bone and the biology around the implant. What is option number 1? Option number 1 is normally only for the acute fractures. That is an additional compression plating of the posterior column. You need adequate bone stock. This is rare in chronic pelvic discontinuities, but in acute fractures it's there. So that is one of the cases where we did it. You see the fracture, there was a trauma before. You see this here, you see this perhaps a little bit better here in the CT scan, and what we did here is we did a plate. I was not happy with the result because what I normally recommend, not to use only the posterior plate, also to use your cup as a plate. It means what I miss here are the screws through the cup to the top and to the bottom. So these are only the screws from the plate. That is, it works in this case, but it was not that what I expected. So sometimes we also made mistakes. And that is something that I really like. So if you look at the literature, there's always the information, do a CT scan. I think the GD views are really perfect thing to see what is the problem, and here's the situation. You see with the GD views much better than the most of the CT scans, the discontinuity. You see the treatment there. I got it from Bas Mas. We had the best views here, and then you can really compare. You see the problem, you detect the problem, and you see the result. This is another case, and that's sometimes a problem. This is where the patient came 3 months before the accident, everything was fine, then there was a car accident, and you see 3 months later there's a fracture. And then this is a question, is it a pelvic discontinuity or not? So we had then these CT scans, and at the end, we were relatively sure, and that's in this case perhaps not so difficult, that this is only a fracture of the anterior column. So if you are sure, then you can use this type of plates, but this is also a rare fracture. Not so often I've seen this in my life. So in the most of the cases it was then a pelvic discontinuity, and we have underestimated the problem. Option number 2, that's what we did in the past. We bridged the defect and used additional allografts. This was a very traditional mechanical approach. There was no bone ingrow, and the persisting micromotion was the problem. And I only want to show some of these cases, and that's what we have seen very often. This situation was not stable. There was loosening of the cup, and we end up with another revision. Option number 3, we were relatively successful with this technique in the last year. So for example, this implant is not available anymore. We adapted this from the tumor surgeon. We have used such a titanium rib shaft that was conic, and we put it into the ilium, in the dorsocranial ilium, where the most of the bone is, and we got fantastic primary stability. It was not so difficult. We were very fast, and we published this. This is one of the situations. It's an 88-year-old woman. No one should do a threaded cup in such an old lady. You see the fracture was immediately there after the operation, and then we have a very simple solution, because the surgeon had all the problems to find the right place for reaming. You see the old lady lost a little bit of the ischium as well. So that's then a problem, and it heals very nicely 3 months later. We have also some of these long-term results here. This was a man, a heavy man. You see the good bone situation, and then it was possible to use this implant. You see after 11 years, there's also something like a new bone formation. That's what we like to have. This is number 4, and that's the cup cage concept. That what is normally recommended today, because you have the integration of the cup, you can bridge the defect, and you have a fixation along the ring, and it means between the ilium and the ischium. That's fine, that's great. That's another method that was not so successful in our hands and also not in other parts of Germany, only to put in a larger cup that's normally 4 or 6 millimeter bigger than that what you have reamed. Paprosky published this with Sporer, and we couldn't get the same results as he got. This is what we normally do today. This is a dislocation and a fracture of a custom-made implant. It also happens sometimes in these devices. And then is that what we do? We use this cup cage technique with a tantalum wedge. We bridge the defect, and then it works in this specific case very well. This is in another case. There was a fall 1 week before. You see the fracture. You see the dislocated cup. The primary THR was implanted 3 years before. And a CT scan is helpful, but don't forget the Judy views. I really liked it. And we did it here. And this is a little bit a different story. So sometimes, and you see this here, it is not so easy to bring the inferior wing into the ischium. Then we use this, what was described as a half cup cage. The stability is definitely lower, but sometimes it's difficult to reach the result that you wish. So that's why we had problems in this case. You see this, we were too lateral with the inferior wing, we were close to the ischium, that's why we cut it. So this is the concept of the half cup cage. A very similar method that we use much more often. You know, Germany is meanwhile a poor country, so we have to look for cheaper things, and that is the combination of a conventional cage with a wedge. So it means we only want to use the tantalum wedge for the superior part where the bony ingo occurs, and this is also the main loading area, so that we combined these tantalum technique. I think you can also use one of these titanium 3D printed techniques. So we put it in with a conventional cage. That is what we did here. You see the tantalum wedge, and you see the conventional cage. We did it in a lot of cases, and we're really happy with this technique. This is here a 31-year-old male. You see also the pelvic discontinuity here, and in this specific case, it worked very well, because we had problems the problem was the loss of muscle, and with the cup cage, you end up very often with a relatively small head. So that's why we use this combination. It works very well. And number 5, you heard about this already. These are the individualized implants. Perhaps not necessary to mention this again. And in a case like that, with pelvic discontinuity, then you have seen the technique. We use the same company in Berlin as it was in Lyon, I think. And this was it is very simple to use. And I have realized, meanwhile, because you have a 3D printed model, and then you get also the direction and the length for every of these screws. That makes it really simple. And at the end, I had realized that it was cheaper in France. It is 13,000 plus between 13 and 15,000 in Germany, and you mentioned 10,000 here. So, but it is very easy to use. So at the end, my conclusion is the wedges are really a key from my perspective. You can combine the wedges with different types of cages, so that makes sense. And the wedge deliver normally the bony ingrow, and that's really helpful. It can help to stabilize the ring, so it is perhaps not necessary always to do this whole cup cage technique. The ring is always, from my perspective, meanwhile necessary to bridge the discontinuity. It's helpful. Osteosynthesis is rarely indicated, and individual implants are a fantastic solution as well, but a little bit expensive. Thank you very much.